Hello everyone, welcome to yet another ASC e-journal committee monthly presentation. You can't believe it's already the half of the year is already gone, and we are excited to be here again. The topic we're presenting today is the cytomorphologic characteristics of next generation sequencing for positive bile duct processing specimens. This is one of the really interesting topic, and we deal with this really in our day-to-day signing out life as well. So I'm really excited to host this event today. Today we have Reza Mousavi as a presenter of the journal article. He's working as a staff cytopathologist at Beit Israel Deacon's Medical Center in Boston, Massachusetts. He also serves as a vice chair of the ASC Case Studies Committee, as well as he's our enthusiastic member of e-journal committee. Furthermore, at ASCP, Reza is also contributing to the Lab Medicine Journal as an advisory board member in cytology and molecular biology. We were joined by Lavisha Punjabi, who is a junior ad hoc member of the ASC e-journal committee last night, and she hosted a very successful Twitter chat event. She's currently serving as a senior resident in anatomic pathology at Singapore General Hospital, Singapore. We would like to sincerely thank Lavisha for graciously taking the lead for the last night Twitter chat session. With that, I would like to emphasize that you have a chat box in which you can put any questions that you want to ask to our invited author. Dr. Rosenbaum is here with us, as well as to our presenter. And I would hand over the session to Reza. Reza, take it over.
Thank you very much, Sukriti. I actually have to make a correction here that I am a cytologist yet. So not cytopathologist. But well, thank you very much. Can you please confirm if you have my screen now?
Yes, we do.
Awesome. Hello, everyone. My name is Reza Mousavi, and I'm very glad to have the opportunity to present the great study conducted by Dr. Rosenbaum and colleagues on the cytomorphologic characteristics of NGS-positive bile duct brushing specimens. I also want to thank Lavisha for graciously taking the lead for last night's Twitter chat session. Dr. Matthew Rosenbaum is a staff pathologist at Beit Israel Deaconess Medical Center in Boston, Massachusetts, and an assistant professor at Harvard Medical School. His clinical fields of practice are cytopathology, gastroenterology, and bone and soft tissue. His research interests are quality, safety, and ancillary testing in cytopathology and surgical pathology. And now some fun facts about him are that he is originally from Northern California, enjoys board games, and speaks Japanese. Dr. Rosenbaum?
Thank you very much. It's a pleasure to be here.
Thank you. Now let's begin quickly for a brief intro on bile duct brushings. Bile duct brushing cytology is the standard of care for biliary strictures in routine clinical practice, but it's challenging to interpret. Diagnosing malignancy requires caution due to atypia from common benign causes like primary sclerosing cholangitis and the presence of stents for both benign and malignant strictures. The complexity is amplified by relying heavily on a definitive cytologic diagnosis for patients' treatment decisions with no other available tissue specimens before major surgery. While cytology demonstrates a high specificity and positive predictive value for malignancy ranging from 98% to almost 100%, we cannot overlook its poor sensitivity, which typically falls between 8% and 62%. This means that there is a significant chance of false negatives where malignancy may be missed in the cytologic evaluation. In order to enhance the sensitivity of bile duct brushing cytology, additional tests have been introduced, namely FISH and NGS. FISH, by hybridizing DNA probes to specific chromosomal regions, allows for the identification of genetic losses and gains associated with malignancy. On the other hand, NGS utilizes techniques such as PCR to detect specific mutations and genetic alterations. And now let me ask you, Dr. Rosenbaum, could you please provide some background on the utilization of fish and NGS in cytology? And also, I'm interested in understanding their current applications and how these techniques have developed over time, please.
Sure, Reza. Yeah. So, I mean, molecular sequencing of cytology specimens has been around for quite a while. I mean, the easiest one to think of, it's not NGS, but they do a lot of sequencing for Pap smears, for example, looking for HPV, and but the fish really started with urine. Actually, it's called a Eurovision probe set. So basically, it originally was for patients who have a history of high-grade bladder carcinoma, and it's basically to increase the specificity of and sensitivity of testing for recurrence or residual tumor with them. So in general, you can see the fish probe set is more of sort of a general sort of approach, just looking for aneuploidy. So it's looking for sort of abnormal numbers of chromosomes, as well as the 9p21 is a little different. It's looking for a loss of the CDKN2A locus there, which is more common in bladder cancer. That being said, a lot of these mutations, all these abnormalities, are also seen in other malignancies. The only other place it's really been commonly applied, to my knowledge, is bile duct brushings. There have been, I believe, other attempts, but nothing that really has been very commonly used. And next generation sequencing is one of those things where I wish it was used more frequently, because I think it really has a lot of potential in small biopsies, because our specimens are very low processing compared to compared to formalin fixing. So your quality DNA is much higher. So you have much more higher quality unfragmented DNA. So it's in some ways easier to work with for molecular labs. The FDA-approved tests that are commonly done, ThyroSeq, so some of the thyroid testing panels are done with next-generation sequencing. Some of them are expression analysis as well, but ThyroSeq, I believe, is technically NGS. There's a lot of laboratory-developed tests that haven't really reached that same degree of commonality, though. I think it's one of those things where it's unfortunate, because theoretically anything you could do on solid tumors you can do on cytology specimens as well, especially if you just have the fluid. The testing we used in this study is it's technically a laboratory-derived test, and I think most academic centers who are doing this are doing it as LDTs. If you look on Foundation Medicine, other sort of large corporate testing platforms, they tend not to use cytology samples. They use liquid samples for like blood and bone marrow, but not so much cytology samples. I don't think it's something that's impossible, but it's something that just hasn't been done for whatever reason. Maybe there hasn't been enough much cause, but something I'm hoping to sort of research further and sort of try to make more inroads into, sort of as something you'd like to bring a little bit more commonality to it, because I think there's a lot of room for growth.
Yes, of course. Thank you very much. So one of the previous studies of the current paper's authors at Massachusetts General Hospital revealed the importance of using NGS as an additional test for bile-like brushing samples. The study demonstrated that NGS is just as effective as fish in detecting high-risk strictures like high-grade dysplasia or invasive carcinoma. When NGS was used alongside cytology, the sensitivity of bile-like brushing cytology significantly improved from 67% to 85%. On the other hand, fish increased the sensitivity of cytology to 76%, but it did not lead to a significant increase in the area under the receiver operating characteristic curve. Dr. Singhi and colleagues conducted another important recent study that provided further support for the author's conclusion regarding the enhanced sensitivity of cytology when combined with NGS. The study demonstrated that the inclusion of a 28-gene NGS panel that are commonly mutated, amplified, and/or deleted in malignant neoplasms involving the bile-duct system increased the sensitivity of cytology from 48% to 83% without a statistically significant decrease in specificity. when this study was conducted in 2020, there were limited investigations into the cytologic features of malignant bile-like brushing specimens and fish-positive samples. This study was the pioneer in establishing a connection between the cytomorphology of NGS-positive bile-like brushing samples and genetic mutations. The author's objective was to examine the cytomorphology characteristics of NGS-positive bile-like brushing samples in order to assess the correlation between the morphology and the presence of mutations linked to high-risk structures. The authors conducted a review of bile-like brushing samples collected between 2014 and 2017, which were successfully analyzed using their internally developed NGS panel. The NGS panel specifically targeted mutation hotspots and exons from 39 genes, employing an anchored multiplex PCR approach. The step-by-step process of conducting the PCR is included in the paper, but we will not be covering it in detail during this webinar. Here we can observe the genes and exons that were covered in the NGS panel, but I would like to ask Dr. Rosenbaum, how were the genes and exons selected to be included in this NGS panel? And could you please explain which genes are considered early or late mutations, please?
Sure, yeah. So, I'm not a molecular pathologist, and since I don't do assay development, but sort of, especially when you're doing a laboratory-derived test within a hospital, the assay is an ever-changing entity in some ways. So you basically have mutations that you are sort of working to validate, and then you have the mutations that sort of make it into the final assay. So this is actually a relatively early version of the anchored multiplex PCR assay. Now there are significantly more genes and exons that are covered, just sort of added in a rolling fashion in some ways, but then there's sort of the large updates where that's sort of where you go through a large validation trial. So these are basically taken, this is not specific to our specimen type here. So this is used for all sorts of solid tumor analysis. So they look, tumor genome atlases and commonly, papers published regarding common mutations in common cancer entities. They pick sort of the types of mutations of the genes that are commonly mutated in relatively common types of cancer, and they target the exons that are of hotspot mutations and the exons sort of that are possible to sequence. There are some exons that have, for example, high levels of tandem repeats, which can be very difficult to sequence accurately. So there are, of course, limitations just based on any assay. So regarding that, that's sort of how they, in general, do the assay development. Sort of and there also can be requests by clinicians, requests by pathologists, and ones that they think are significant either from a diagnostic or a treatment or other sort of clinical utility. From there, basically, we looked for our definition of late mutations. We looked at ones that are commonly mutated in this case, cholangiocarcinoma. So it's going to have things like P53, SMAD4, and CDKN2A, which, as you remember, is one of the probes covered in the Erosion fish assay. So those are the ones just picked because they are common mutations in high-grade lesions. So you can argue, you can see that in cholangiocarcinoma and high-grade dysplasia as well. So those are the ones you look at. If you see those mutations, it's considerably more worrisome than seeing something like a KRAS mutation. So KRAS mutations can be seen in sort of low-grade dysplastic lesions. If you're talking about pancreatic cysts, the KRAS and GNAS can indicate a low-grade pancreatic cyst. But if you have a KRAS and GNAS plus one of these more higher risk mutations, like P53 being sort of the most common, or most well-known one, that is substantially more worrisome because P53 is associated with a sort of more aggressive clinical behavior. Even if it doesn't end up being cancer, oftentimes it's with high-grade dysplasia or other more concerning lesions. So it's more going from those research studies that correlate mutations to the clinical status, and then we sort of take that and go back to our molecular analysis and reapply it, saying, okay, we use this to indicate evidence for a high-risk lesion. We don't use it ever to define a high-risk lesion, but we use that as a risk factor, something that definitely creates a level of concern.
Yes, certainly. Thank you very much for answering this question. In this study, a total of 74 SurePath liquid-based preparations of bile-like brushings with positive NGS findings, which included clonal somatic mutations detected through NGS sequencing, were evaluated. Additionally, 22 bile-like brushing samples with negative NGS results, indicating the absence of mutations or the presence of only germline mutations, were also included in the evaluation. Two pathologists, Dr. Pitman and Dr. Rosenbaum, assessed 29 cytologic features in these samples. Importantly, both pathologists were blinded to the original cytologic diagnosis and NGS results to ensure unbiased evaluation. Now, under low power magnification, the slides were evaluated for various factors, including overall cellularity, the number of cell groups, the number of smaller cell clusters, and the number of single cells. Specifically, the assessment involved categorizing cellularity as less than 10 cells, between 10 and 100 cells, or more than 100 cells. The number of cell groups, defined as collections of 10 cells or more, was noted as either less than 20 or 20 or more groups. Similarly, the number of smaller cell clusters, defined as clusters containing 2 to 9 cells, was categorized as less than 20 or 20 clusters or more. The presence of single cells was also recorded, classified as less than 20 or 20 cells or more. Additionally, the slides were examined for background characteristics, including clean, bloody, or the presence of acellular granular debris. Furthermore, the presence of naked nuclei and the extent of acute inflammation was considered during the analysis. Now the fun part, the images. In figure 1, we can observe a bile-like brushing sample demonstrating cytomorphologic 3-to-1 anisonucleosis and a background characterized by a dirty granular appearance. Subsequently, the slides underwent analysis for low power and cytoplasmic characteristics. This assessment encompassed evaluating architectural disarray, indicating the loss of the typical honeycomb pattern. The presence of a cell within cell pattern was also examined. Additionally, the analysis involved assessing intracytoplasmic mucin and an increased depth of focus, giving a sense of three-dimensionality. Next image, figure 2, illustrates the architectural changes observed in bile-like cytology specimens. In part A, the bile-like brushing sample exhibits a regular honeycomb appearance. The cytology was categorized as negative. NGS result was also negative, and the clinical follow-up confirmed the benign condition. For part B, the bile-like brushing sample displays a loss of regular honeycomb appearance and contains a mixture of inflammatory cells. The cytology was considered atypical. The NGS result was negative, and subsequent biopsy revealed ulceration without malignancy. And lastly, part C, the bile-like brushing sample demonstrates a complete loss of regular honeycomb appearance and exhibits hyperchromasia. The cytology was categorized as suspicious. NGS indicated positive findings for late mutations, and the follow-up biopsy confirmed the presence of adenocarcinoma. The nuclear characteristics evaluated consisted of several factors, as you can see here, including nuclear megaly, where the nuclear size is 3 times larger than that of a normal ductal cell's nucleus, nuclear molding, the presence of mitosis, apoptosis, irregular nuclear borders, and increased NC ratio above 0.5. Anisonucleosis, which is defined by variations in nuclear size within a group or cluster of cells in a 2-to-1 or 3-to-1 ratio or higher, nuclear hyperchromasia, angulated nuclei, coarse chromatin, irregular chromatin distribution, parachromatin clearing, and the presence of nucleoli, which could be indistinct, present, or prominent. In figure 3, we have the nuclear changes observed in bile-duct brushing specimens. In part A, bile-duct brushing sample exhibits no nuclear atypia or abnormalities. The cytology was categorized as negative. NGS result was also negative, and the follow-up confirmed a benign condition. In part B, the bile-duct brushing sample displays nucleomegaly and an increased NC ratio. The cytology was considered atypical. The NGS result was negative, and subsequent biopsy revealed an ulcer without malignancy. In part C, the bile-duct brushing sample shows an increased NC ratio, irregular nuclear borders, and prominent nucleoli. The cytology was labeled as atypical, and the NGS indicated the presence of late mutations. The follow-up biopsy confirmed the presence of adenocarcinoma. And lastly, part D, this bile-duct brushing sample exhibits nucleomegaly, an increased NC ratio, irregular nuclear borders, and coarse chromatin. The cytology was signed out as adenocarcinoma. NGS revealed late mutations, and the follow-up biopsy confirmed the presence of adenocarcinoma as well. Dr. Rosenbaum, here I would like to ask about your experience in data collection process. Could you please explain how you incorporated the abnormal cytomorphology criteria that you designed for your study during the data gathering process? And additionally, could you please elaborate on how you performed the clinical pathologic follow-up, and if there were any other considerations regarding subgroup analysis, please?
Sure. Yeah. So regarding sort of the data collection, dealing with a large number of cytologic features in a moderate number of patients. 100 patients isn't actually too bad for a study like this, but dealing with 26 different cytologic features can be very difficult to to handle. There's basically a high tech and a low tech way. The low tech way is you blind, basically you have your case assigned a dummy number, and you have a list of your features, and as you go through on a group scope or individual scopes, you type in your finding in each one. So you sort of have a number key, for example, we could say a 0 to 1 indicating something is present or negative, or if you want to indicate a larger scale, 0 to 5 kind of thing like that, and you just type in your number as you go through your characteristics. As long as you go through it in a relatively regular way, it becomes relatively quick. The other way to do it is sort of the low-tech way. You just have a score sheet for each case, and you sort of write in your value or your diagnosis or your impression for each of the features as you go through it as well. This one we actually chose the low-tech way because it's just easier to blind, and we were working with some other people as well who thought that was sort of the better way to go. As long as you sort of trace everything back to the proper case, it's very easy to do. It's just important to sort of make sure everything is checked and double checked by multiple people, because if you're doing a large amount of data analysis, of course, it is critically important that sort of all the numbers add up properly. Regarding that, we also sort of synthesize everything into a general diagnosis of just saying, okay, based on our experience, based on sort of the number of cases we've seen, we would call this atypical, suspicious, or positive. That was completely gestalt. That was sort of ignoring the granular data, and just if we're approaching this purely as cytopathologists, without doing any sort of higher level sort of granular detail, picking out individual cytologic characteristics, how we would make that diagnosis, just sort of in a standard vacuum. In the subgroup analysis, you're kind of limited by your population. It'd be great to sort of do multiple subgroup analysis, but you have to have a sort of that critical number to make the subgroup analysis worth doing. Like, it'd be interesting to pull out each individual late mutations, like is p53 cancer associated with a different phenotype than SMAD4 mutant cancers, for example, or cases. There just weren't the sheer number of cases to do that. We had 39 cases of all the mutations grouped together, and in terms of reaching statistical significance, in some ways, clinically speaking, a concerning mutation is a concerning mutation. There are theoretically degrees of concern, based on sort of the clinical pathologic data. but we didn't really have enough numbers to really make that kind of analysis feasible, as interesting as it would be. So, practically speaking, a late mutation is considered a worrisome feature by our clinical teams. So we just lump them all together, and you sort of use that as a higher, to create sort of a higher powered analysis where you can just say, oh, these are the worrisome features associated with these worrisome mutations. So in the end, you're limited by your population, but you're also limited by what is clinically important and what subgroup is going to result in meaningful data, because doing a subgroup analysis can basically just double your work. So you want to make sure that that data, and if you slice a pie in the right way, you can get any result you want theoretically. It sort of allows for, and theoretically you could do sort of more data manipulation, which is why we just decided that we're just going to put all of these in one group to prevent us from getting a more skewed population. So you're limited by your what is clinically relevant, or you should be limited by what's clinically important or clinically actionable, and by your population and your numbers. So that's sort of how we decided to do our subgroup analyses.
Yeah, it completely makes sense. Thank you very much for your comprehensive answer to this question. Now diving into the results section of the paper. The study consisted of 74 NGS positive bile-like brushing samples obtained from 66 patients, along with 22 NGS negative samples from 22 patients. Patient outcomes were compared with the cytologic impression, which itself classified as positive or not positive. And non-positive cases included negative, atypical, and suspicious categories. Patient outcomes were also compared with NGS positivity and mutation status, classified as late mutations versus KRAS gene S only. While routine cytology findings exhibited high specificity for malignancy, false negative results were frequent. 84% of malignant cases were not initially identified as malignant by cytology. Concerning NGS status, 58 out of 66 NGS positive patients, around 88%, were found to have malignancies based on clinical pathologic follow-up, whereas none of the 22 NGS negative patients showed malignancy. Table 2. In terms of low power impressions, the presence of a significant number of single cells above 20 showed a weak association with NGS positivity. Specifically, 71.6% of NGS positive cases exhibited numerous single cells compared to only 45.5% of NGS negative cases. Similarly, the background characteristics provided suggestive evidence of NGS status, as lower number of NGS positive cases had a clean background in comparison to NGS negative cases. However, the presence of cell groups, clusters, background inflammation, and naked nuclei did not demonstrate a significant correlation with NGS positivity. When considering the architectural and cytoplasmic characteristics, the presence of architectural disarray demonstrated a strong association with NGS positivity. Specifically, 66.2% of NGS positive cases exhibited architectural disarray, whereas only 22.7% of NGS negative cases showed this feature. However, an increased depth of focus, intracytoplasmic mucin, apoptosis, and cell-within-cell morphology did not exhibit a significant association with NGS positivity. Regarding nuclear changes, an increased NC ratio, nuclear megaly, 2-to-1 anisonucleosis, 3-to-1 anisonucleosis, irregular nuclear borders, and nuclear hyperchromasia all demonstrated associations with NGS positivity. Visible and prominent nucleoli were more frequently observed in NGS positive cases, while NGS negative cases predominantly exhibited indistinct nucleoli. There was no significant association between NGS positivity and features such as mitosis, nuclear molding, angulated nuclei, coarse chromatin, irregular chromatin distribution, and parachromatin clearing. Considering the overall characteristics of the cases, the presence of abnormal groups, clusters, and single cells were all associated with NGS positivity. Furthermore, the overall impression based on cytologic evaluation showed a strong association with NGS positivity. This significance persisted when cytologic positivity was defined as suspicious or worse. So using an overall cytologic impression with a cutoff at suspicious, the sensitivity for detecting malignancy was 33% with a specificity of 100%. Similarly, the sensitivity for detecting NGS positivity was 27% with a specificity of 100%. But now using a cutoff at positive, the sensitivity and specificity for malignancy were 16% and 100% respectively. While the NGS positivity, the sensitivity and specificity were 12% and 100% in order. Notably, NGS positivity itself exhibited a sensitivity of 100% and a specificity of 73% for detecting malignancy. And the last table, when comparing cases with late mutations, 39 cases, to those with only KRAS GNAS mutations, 16 cases, several differences were observed. And specifically, the presence of naked nuclei, nucleomegaly, 2-to-1 anisonucleosis, and coarse chromatin was more prevalent in the late mutation cohort. Furthermore, the presence of abnormal groups, clusters, and single cells, as well as the overall impression, correlated with the status of late mutations. Although these differences did not reach a statistical significance, there was a noticeable trend towards an increased NC ratio, nuclear hyperchromasia, and enlarged nucleoli being more common in samples with late mutations. Now, beginning the discussion part of the paper, the authors have demonstrated that various characteristics observed under low power and high power magnification are linked to NGS positivity in bile-like brushings. Features like naked nuclei, nucleomegaly, 2-to-1 anisonucleosis, and coarse chromatin were more frequently observed in specimens with late mutations compared to those with only KRAS GNAS mutations. There was considerable overlap in cytomorphologic features between benign and neoplastic groups, making it challenging to attribute a specific morphologic feature exclusively to the presence of malignancy. These findings emphasize the high rate of false negative results in bile-like brushing cytology and the importance of an indeterminate diagnosis due to the association of atypical or suspicious cytology findings with late mutations identified through NGS. It is worth noting that reducing the threshold for defining atypical findings improves the sensitivity for detecting NGS positivity, but it may come at the expense of specificity. Cellular and nuclear abnormalities were observed in cells of various sizes and were found to be linked to NGS positivity and late mutations. However, the association was more pronounced when these abnormalities were present in single cells and small clusters, meaning 2 to 9 cells, rather than in larger groups. The increased significance of cytologic abnormalities in single cells and small clusters can be attributed to the presence of these malignant features in discohesive cells. It is worth noting that this cohesion is frequently observed in carcinoma compared to reactive processes. This finding aligns with previous reports in fish-positive bile-like brushings, further supporting the correlation between cytologic abnormalities in single cells and small clusters and malignancy. The overall impression of cytology is strongly correlated with NGS positivity. This correlation is expected since the overall impression combines the quality and quantity of atypical features. At a suspicious cutoff, the cytology impression had a sensitivity of only 27% for NGS positivity and 33% for malignancy. When using a positive cutoff, cytology showed a sensitivity of 12% for NGS positivity and 16% for malignancy. By setting the cutoff at atypical, just lowering the threshold, the sensitivity for NGS positivity increased to 85%, but at the cost of decreased specificity, as mentioned earlier, now close to 72%. NGS demonstrated high sensitivity of 100% for detecting malignancy. Also, while the presence of late mutations also had the highest specificity for 100% for malignancy. These results all highlight the valuable detailed information provided by NGS. Many of the cytologic features linked to NGS positivity were traditional features of malignancy resulting from reduced cell cohesion and nuclear chromatin abnormalities associated with malignant transformation, some of which have been previously documented. However, certain characteristics potentially associated with malignancy or neoplasia, such as cell-within-cell orientation, intracytoplasmic mucin, apoptosis, increased depth of focus, and nuclear molding, were not found to be associated with NGS positivity. It is worth noting that intracytoplasmic mucin was observed equally in both cohorts, likely indicating a reactive change rather than a specific marker for malignancy. Additionally, these other features were only observed in a small number of NGS positive cases, limiting this study to establish significant differences. Authors previously observed that the utilization of NGS with a 39 gene general solid tumor panel as an additional test for bile-like brushing cytology has been beneficial. It increases sensitivity from 67% with routine cytology to 85%, which was higher than the sensitivity of 76% achieved by FISH. Similarly, another research group demonstrated a significant enhancement in the effectiveness of biliary cytology in patients with primary sclerosing cholangitis, where bile-like brushing cytology traditionally exhibited low sensitivity due to reactive changes, even in benign PSC strictures, but they managed to raise the sensitivity from 8% to 83%. Now, limitations of the study. This study had certain limitations, including the subjective nature of the features assessed and the characteristics of the patient cohort. The evaluation of many characteristics relied on subjective interpretation of their microscopic appearance, as morphometric analysis was not used. However, considering that morphometry is not commonly employed in clinical practice, the authors deemed traditional microscopic analysis more relevant for general practice. Although the study had a reasonably large patient cohort and covered a wide range of morphologic analyses, some of the microscopic findings were infrequent, which limited the achievement of a statistical significance for certain characteristics. Additionally, not all patients underwent surgery for definitive tissue diagnosis, particularly in non-malignant cases, leading to reliance on clinical follow-up data for final diagnoses. Furthermore, the significance of overall judgment may have been underestimated, as the cytology was assessed in isolation without the benefit of clinical, ancillary, or concurrent specimens. Dr. Rosenbaum, another question for you. I'm returning to you for this question: that how did the subjectivity in examining the features impact the reliability and reproducibility of the study's findings? From your experience, could you also please provide some recommendations for addressing and improving this aspect in future studies with similar methods?
Sure. So yeah, I mean, a lot of these are somewhat subjective. I mean, you could argue that because we were not using strict morphometric analysis, which once again, the vast majority of cytologic morphology studies do not do. Which it's just they're very good, but they're just very cumbersome. I think as digitization really takes off, as well as AI analysis, things like that, I actually think morphometry will become more common and perhaps become the gold standard in time. This is, quite a ways down the line. The increased sensitivity in some ways decreases your reliability, but increases the practicality. So what I mean by that is, of course, we didn't measure exactly the diameters of the cells to get which is a 3:1, which is a 2:1, which is a 1:1 ratio. But that being said, generally speaking, people don't do that. So you make the judgment sort of based on your best judgment and sort of based on your cutoff sort of within your head. So I do agree that any of these studies that do use sort of cytologic analysis without, or morphologic analysis without morphometry, does sort of have that limitation to that. But that being said, like I think pretty much all cytopathologists make their judgments based on these kinds of things. In a way though, being as specific as possible and providing very granular different things. Like we didn't just say atypical cells. We had the distinct nuclear features, we had the different ratios, we had membrane irregularity, we had coarse chromatin, we had hyperchromasia. We sort of if you're talking about a single feature, doing it as a plus or a minus, your intraobservable variability will generally get better, which is why it's like, for example, if you combine, if you do sort of combined, SYN 2 and 3 in gynecologic pathology, you're going to get a higher intraobservable variability versus 1, 2, and 3. Is because sort of the more granular you are, sort of the more when you focus on sort of the more significant findings and just say, is this A or B? People are generally speaking able to do better than giving them additional findings. And I think because we did have 2 pathologists on that, it sort of allowed us to have a degree of sort of discussion of whether or not this is something that everyone would agree on too. So in a lot of ways, it is definitely a limitation of the study. I don't disagree with that, but in a lot of ways, there is sort of limitation of our just day-to-day practice. Regarding your second one was improving it for future studies. I mean, as I said, sort of the idea is as sort of digital analysis becomes better. I mean, I think you could do crowdsourcing. You could have 100 cytopathologists on Twitter weigh in on whether or not you think something is a 4:1 or 2:1 or something really represents hyperchromasia or not. So you could do that. You could do, digital analysis. You could have really strict morphometric criteria. As long as you have those digital images that are unchanging and everyone is looking at the same image in the same field of focus with the same light on the same microscope. Everyone sort of has examples where certain things look a little bit different under different microscopes based on the light source and how, just how the microscope is set up. So I think, as digitization becomes more of a norm or becomes more widespread, or they get better at digitizing cytology slides, which do have a degree of three-dimensionality to them, I think that will improve things in the future. But sort of if you don't have that technology, if that's not part of your study, I think the idea of including additional people, sort of making sure that you have a degree of consensus and being very specific about your criteria and making your criteria as granular and sort of making the differences as clear as possible would be the way I would go about sort of making these diagnoses or this analysis as stepwise, and it's never going to be completely objective, but you strive for getting a practical level of objectivity. You don't want to say like, oh, this feels, you said we did try to capture even more subjectivity by just saying like having a negative, atypical, suspicious, positive diagnosis just based on how we felt about it, and that's to sort of capture just the gestalt subjectivity of that. But sort of the idea is when you're doing a sort of granular analysis, you want to minimize that as much as possible. So that's sort of how I would go about it personally.
Of course, thank you, and I completely agree with you. And now the conclusion of the paper. The cytomorphologic evaluation of bile-like brushing poses challenges due to the presence of overlapping morphologic characteristics among non-neoplastic, low-grade neoplastic, and malignant bile-like structures, leading to a considerable false negative rate, as mentioned earlier. While certain features like naked nuclei, nuclear megaly, 2:1 anisonucleosis, and coarse chromatin exhibited significant differences between bile-like brushings with late mutations and those with KRAS genus mutations only, there was still considerable overlap, making it really difficult to establish a definitive malignancy diagnosis in many cases. Given the limited sensitivity of routine cytologic analysis, incorporating NGS as a reflex ancillary test proves to be valuable in enhancing cytology sensitivity and providing specific mutational details for identifying high-risk and malignant structures. And my last question for you, Dr. Rosenbaum, is that what are some factors that laboratories should consider when deciding whether to implement NGS for biliary brushing specimens? Additionally, could you please provide some insights into the cost implications of performing NGS compared to fish in this context?
Oof, those are okay. Those are the two most complex questions. So I guess we can talk about maybe the cost first. That's sort of the easier one to deal with. It really depends on your assay and your reimbursement. So you have to work with your payers. A lot of next generation sequencing is not reimbursed at all, or it's reimbursed at a very low rate. So there has to be sort of a degree of discussion and negotiation with your payers on that. Otherwise, you won't get any reimbursement, and you'll be doing it sort of as purely as a research tool, and you can't really, it's not really sustainable. So that's sort of an important thing for that. The fish in general, the fish in general is reimbursed for certain populations. For example, primary sclerosing cholangitis screening patients, fish is generally going to be reimbursed. If you're doing both in-house, it kind of depends on that. So most times fish is going to be sent out. So you're not going to be making money or losing money on it in general. This all, of course, is very hospital specific. In terms of the actual cost of performing the assay, depending on how well optimized or how in-depth your sequencing is, what platform you're using, theoretically, an NGS wouldn't cost any more than the fish. There's a lot of factors going into that. Theoretically, cost-wise, if you can bring it in-house and you can sort of keep your volume up, your costs down, have good negotiations with your payers, is a theoretical possibility. This is not, I did not run the lab, so this all happened way above me and in sort of the next building over, in terms of saying whether or not it was actually a profit maker or a profit loss. So it sort of comes down to that for the cost for it. And I think that is a hugely important thing. If you cannot sustain your lab, then you can't continue providing that service. So I actually think that is hugely important, but unfortunately, it sort of goes certainly beyond my expertise, sort of in terms of negotiation with the payers. I mean, I certainly just think it is worth it in certain circumstances, but insurance, doesn't always see things the same way as pathologists do. The factors about whether to implement NGS sequencing is also really, really interesting. I think the very easy parts are workflow, making sure you are able to split up your sample appropriately so you're able to provide cytologic diagnosis as well as your next generation sequencing diagnosis, making sure you have the proper staffing, your transportation network set up very appropriately so no specimens get lost, things like that. That's all well and good. The real important thing is you're liaising with the clinical team, because if they're not going to use this data, there's no point in generating it. Your clinical team has to be comfortable with that data. They have to want that data, and they have to be willing to act on that data. Because if they're not going to act on it, it's not so much there isn't a point to doing it, but the fact is then you're not necessarily bringing anything to the table for the treatment of your patient. Where we did the study at Mass General, the clinical team really did want this information, and they were comfortable acting on it. So in the absence of a cytologic diagnosis, they were comfortable changing things up, changing their management of a patient based on their NGS results and the NGS results alone. And in that context, that makes that very useful, that they want that data and they're willing to work on that data, work with that data to act on it for patient benefit. Because if it's not going to benefit the patient, it's not sustainable, and you can't benefit the patient. It's not something that you can do, you can't do long term. And there's no point in sort of bringing that in if it's something you can't do long term to benefit your patients. So that's sort of the main thing, I think, is honestly sort of your discussion with your clinical teams on that, or is there interest from the clinical teams on that? And I think it really has to be people passionate about it on both sides. Otherwise, it's just not going to continue.
Yeah, of course. That was a really great piece of information. Thank you very much for answering this question. And also, I would like to thank you very much for your time, for joining us today. And I would like to also thank Ms. Joanne Jenkins, Dr. Rizai, and Srikriti for their support at the ASCP Journal Committee. And I would be very happy to answer questions. Also, Dr. Rosenbaum is here for answering the questions if there are any.
Thank you so much, Reza, for doing a wonderful job. Thank you, Dr. Rosenbaum. Reza kind of got a very extensive questions and answers from you. Great job, Reza. I have only one last question, unless we see something popping up in the chat box in the next 2 or 3 minutes. Dr. Rosenbaum, in our clinic, I practice at Columbia University, and we do have an in-house fish, and we routinely, clinicians routinely reflex in-house fish sample whenever there is a clinical suspicion. But if the fish is negative, how do you suggest that we should, answer the clinician if they are worried and if they want to send for next-in sequencing?
Yeah, I mean, the fish is actually still pretty good, honestly. So I would consider the fish to be highly specific, but a bit less sensitive than next-generation sequencing. The problem is, though, you can, especially with the fish, you can only test the cells that are on that you get on your fish slide. Next-generation sequencing is a little bit better in the sense that you can, one, test more cells, and two, you do get some cell-free DNA in sort of that supernatant as well that sort of gets, analyzed well, not inadvertently, but in addition to that. I would recommend, I'm sure this is exactly what you recommend. I'd recommend resampling if there's a high degree of clinical certainty. If your cytology is positive and your fish is negative, I mean, I think a positive cytology sort of takes precedence. I mean, I have to say that as a cytopathologist. I, of course, would urge caution based on the negative fish, but, the specimens are never divided equally. Some things may get into the cytology that don't get into there, and certain, mutations and certain things will not show up on the fish probe. Like I said, the fish is highly specific, but I think its sensitivity is only around 70 to 80%, depending on the population that you're testing. I assume mostly PSC patients. It's going to be very tricky. But that being said, PSD patients are also the hardest ones on the cytology level too. I think we published another paper too with the GI group in cancer cytology talking about NGS evaluation specifically in PSC patients. And the sensitivity and specificity of cytology in that setting is not amazing. So I think, especially if you're going to take a patient if you take a patient a biopsy, I think they should definitely take a patient a biopsy if you have a positive cytology negative fish. If you're going to take a patient to transplant or to basically, a major resection, that's a trickier thing. I think you really have to have that conversation. But in the end, I would say, cytology, at least in our experience, has been very specific at the degree. Once you get the positive, it's very specific. Suspicious is still pretty specific, but I think most people will be hesitant on taking a patient to surgery at suspicious, but that is sort of a department-specific kind of thing.
Right. Like you mentioned, we have a lot of primary sclerosing cholangitis cases here, and if we are really suspicious about some atypia more than what you could see, and we usually like to use the phrase of atypia neoplasia cannot be entirely excluded, and talk to the clinician. If there is no concurrent phase, suggest them to send for a concurrent phase. And usually our phase has a turnaround time much longer than the cytology turnaround time, so we end up seeing our cases and wait for the fish results afterwards.
That's what I was going to ask you. Do you ever go back and addend your cases with the fish results, or do they just result separately?
They result separately, but everyone, the signing out pathologists, do get a copy of the fish report.
Okay, great.
That's why.
That's very useful. Yeah, that'd be very good to sort of go back and review your typical ones with fish positivity. I don't know if I mentioned this, but the fish will only be positive generally in high-risk lesions where you do have, massive chromosomal aberrations or that CDKN2A loss, which is once again a high-risk feature. So, more for the people listening, is that that fish positivity doesn't necessarily mean neoplasia. That fish positivity is very concerning, at least in our department. I assume in your areas too. So.
Anyway, thank you so much. I do not have any more questions in my chat box. Thank you, Reza, for doing a wonderful job. Thank you, Lavisha, if you're listening to this, for yesterday's wonderful Twitter chat event. And thank you, Dr. Rosenbaum, by gracing us with your presence and answering all the questions. Audience, this is the end of it. If you haven't registered for ASC meeting in November, do. See you next month in August. Thank you, everyone. Have a great rest of your day.
Thank you very much.
Thank you.